Good morning, everybody, and thank you for coming on Sunday morning. We're going to be presenting the Learning from the Front Lines Community Rapporteur Session, and this is with participants of the CATIE Learning Institute, who you might have seen walking around with these black little notepads and templates and scribbling around and paying attention generally. And my name is Michael Bailey, and I'm Director of Program Delivery at CATIE.
Good morning, it's nice to be here. My name is Uzawa Panisi from Regina, Saskatchewan. I'm a frontline worker. There's many struggles that we face here. I've had the opportunity to learn a lot and to meet a lot of people. Very honored for this opportunity. So on behalf of the Canadian Learning Institute, I'd like to acknowledge and extend my gratitude and respect to the Coastal Salish territory for having this event here, and to welcome me from the Treaty 4 and the other participants. Thank you.
So we're going to be presenting the community lens on the 4 tracks that were presented here at CAHR. But I'm going to give you just a little bit of a background about our Learning Institute. This year we have 32 people here, including the CAHR scholars, and CATIE-sponsored people coming here. And they're from across Canada. There are people who work in community-based organizations, nurses, some community-based researchers. And our goal was to attend the conference and make the linkages with community, to see what gaps were there, what might influence the programs in our own organizations. But that community lens, we very quickly realized that there were so many community lenses because all of these people come from different communities. So we met each day for 3 hours, yesterday and the day before, after our full days of attending the conference. And the discussions were really great. We were always nervous at the beginning that people will just be too exhausted, but the enthusiasm was really inspiring, and I'd like to tell the people who did attend, the rapporteurs, that the CATIE people, we were so inspired by you too. So what we're doing today is giving a little bit of a distillation of our discussions. And when we got to the point yesterday of actually working on the slides, the power went out. So we were racing against time with the batteries of our laptops to get this done, but I think it's pretty good. So we're going to go through the 4 tracks, and I'll be inviting the first person up to do the basic science track. Thank you.
Good morning, everyone. I'm Laura Toole with the AIDS Coalition of Nova Scotia. I'm really happy to be here in Vancouver for this conference. Our group looked at the basic sciences, and I want to first extend my thanks to our very small and mighty group, and also extend my thanks to Sharik, who is hiding in the back here, who helped our community folks interpret some of this basic science information, which was very challenging. So thank you very much for that. So for the purpose of this presentation, I am just going to read the information from the slides because I am a support worker and not a scientist, and so in the purpose of getting the information correct, I am just going to read it. So these are some of our key findings. An integrase inhibitor called dolutegravir, the only known mutation is R263K, which comes at a virus fitness cost. The R263K mutation has not been found in people. The term viral fitness is described as the strength of the virus and the ability to adapt, and that's something that came up in a few other presentations. Gene therapy is when DNA is introduced to a cell. Proteins are secreted and they can inhibit HIV infection in the absence of ART. Reactivation of latent virus can be harmful. This can lead to the development of drug-resistant recombinant viruses. A study has shown TAF is less harmful than tenofovir because it does not interact with renal transporters. IL-7 is a pivotal cytokine essential for T cell survival and function. T cells need IL-7 to function. HIV messes with the CD127 receptor on the outside of the T cell, which is where IL-7 connects to communicate with the cell. So as you can see, our language was where science met community. And how, of course, we would explain this to some of our clients, which is most important. Th17 cells are depleted following HIV infection, which leads to reduced control of bacterial infection. Heart does not restore Th17. So then yesterday morning, we had the pleasure of going to the Plenary, which was on the search for the HIV vaccine. So some of the challenges of developing a vaccine was HIV variability, hard to find commonality due to mutation and diversity, the term genetic bottleneck, which many substrains may be transmitted from one person to another, and only one strain will survive and continue to reproduce. Broadly neutralizing antibodies, they're very rare because all of this variation, it's hard to find one antibody that will work for everyone. Cellular immunity, if we can block infection, we need stronger immune system response and ways to help it happen. Viral fitness, as I discussed earlier, if we can't do that, then a way to make the virus pay. So, for example, we can make it weaker and less likely to survive and progress. Finally, we can be thinking beyond simply blocking infection. We can be looking at vaccines that not only block infection, but also, if this fails, helps prevent HIV progression in the body. So then in the morning, there was sessions on HIV transmission and evolution. Mucosal surfaces are the first site of contact for HIV. By examining highly exposed seronegative women, researchers can find natural anti-inflammatory and antiviral properties. This can be used for preventative efforts. Sperm washing is an effective method in removing HIV from sperm. Researchers are using ancestral reconstruction to find the sequence of the original virus, which may lead to the discovery of sequence patterns at the time of infection. Genetic correlates of protection and risk are being studied with different populations. One study looked at how the virus has evolved over the years to examine virus fitness. So then in the afternoon, there was more sessions in the basic science. IL-18 is a protein that causes inflammation, and IL-18BP helps to control it. Long-term non-progressors have higher levels of IL-18BP. HERC5 is a natural protein that can inhibit late-stage HIV replication and another place to block HIV in infected cells. We talked a lot about NEF last night with Power Out. So NEF is an HIV protein that helps to invade the immune system by disarming a cell's ability to signal it's infected. Elite controllers have viruses with lower NEF function, which could be because their immune system is better at attacking viral NEF, and or the virus they got infected with has a weaker NEF. One study, Sharik study, sought to explore how to reverse the effects of NEF in the help to prevent HIV's invasion from the immune system. And now I'm going to pass it over.
Hello again. As I said, I'm from Regina, Saskatchewan. I'm going to be discussing some things relating to the Indigenous point of view. Throughout my time here, I've had the opportunity to listen to some very dedicated, educated, and passionate people in the HIV movement. One in particular, Dr. Clive Aspin, pointed out that Indigenous people from around the world face similar challenges when it comes to HIV, in particular New Zealand, Australia, and Canada here at home. A lot of these problems are stemming from the colonization and a paternalistic attitude of today's society towards the First Nations, Indigenous people. I think that really has to be addressed. I also attended Margaret Poitras's excellent workshop on the findings of the 8-track survey, which was done from December 2011 to June of 2012. And some of the things that were highlighted there was that in 2011, there was 186 new cases in Saskatchewan. Of that, 81% were First Nations people. So now there's something going on there, which we have to get to the bottom of. There's a disproportionately high number of First Nations people contracting HIV. Of the 54 self-identified people with HIV in this study, 25 of them didn't know that they had it at all, so they continue to pass this on. I believe we have to get to the root cause of the problem, as many of my coworkers and the people I work with in the community have to agree with. And we have to get to the root cause, and that's from the colonization, from the residential school. I believe we're still affected from the effects. I'm a residential school survivor, so I know firsthand. I'm very glad my children are healthy and doing good, but it's very frightening here, some of the things back home here that we face, and that's my point of view on the way I see things here. Again, I'd like to reiterate that it was very nice to be here and to meet people and to learn and to continue to expand my knowledge. One thing, I was talking with some people and I noticed that we need each other, people at the grassroots level, like people like me, AFAs, Aboriginal people with HIV and AIDS and PHAs. We need the researchers, we need the doctors, we need to come together because we need to be included in the development of policy, the development of programs, because we know firsthand what we need out there. So I think in Saskatchewan, anyways, we need to be included more in the discussions and development of policy. And I know that's needed across the board to really get to the heart of the matter, to what we need out there, is to work together. The old people say we're all related, we're all connected. We're all connected. So I look forward to dedicating my life here to working in this field and to learning. A lot of the terminology was way over my head, but I still had a great time, and I speak from my heart, and for all the people that couldn't make it here, there's a lot of us. There's 12 of us from the Canadian Learning Institute that received these scholarships. So I'd like to just thank you all and thank CAHR for giving me this opportunity to take part in this and to learn and to expand my knowledge. Thank you.
Good morning, everyone. Thank you for having me, and thank you, Daryl, for your comments. It is true we do need to start working together, or else we're never going to achieve the problem or achieve the solution to the problem which we face. Much like Daryl, the lingo is way over my head, and I apologize if I butcher this, which I probably will. Clinical sciences is not my forte, one might say. I definitely say that, so here we are. Okay, so, oops, I keep hitting the wrong button. I gotta learn how to work this first. Okay, so the plenary for clinical sciences was extremely interesting. PrEP is a tool which we know can, when used effectively, be quite effective. Unfortunately, PrEP is not used effectively in most instances. I think it's very, I don't want to say unfair, but I don't think that it's right or sensible that we believe that someone who doesn't need to take a drug for any specific reason other than their own potential benefit to do it every day. I know that sounds crazy to most of us who think because it could actually save your life and save you from getting infected with HIV, most people, and I shouldn't generalize, but most people don't view that way. And I think a great quote that we have is, an effective tool used incorrectly or inconsistently is reduced to an ineffective tool. And from the plenary, I think that was a very good point which we got. And I think hopefully if we can try to get PrEP working, which I'll go into PrEP a little more with slides, that we actually will can make it beneficial for everyone and really help to stop the spread of HIV. Okay. So HIV and Aging was one of the sessions for the clinical sciences which we went to. And we have found that, well, we know as we get older and we age, we are prone to many different types of conditions, health conditions. The difference is that in HIV positive people, we notice that it's about 5 to 10 years earlier. So we need to learn how to address these issues, and which I'm going to talk about earlier, the next generation sequencing to attack these infections and these mutations before they start. So hopefully as we get along further, we can figure that out and stop it and let HIV infected people live longer than, or equal to their negative counterparts. Hopefully longer, but who knows. We also learned that high rates of bone abnormality in HIV positive women in BC is a big issue. 30 to 50% of HIV positive people have mild to moderate cognitive impairment, and HCV has a negative adverse effect on this. Also, close to 100 new studies in the last year on HIV and brain health. So definitely a study, an area of interest for most of us, and we really appreciate all of the studies that have come to date. We do know that increased life expectancy of persons living with HIV is not equally experienced by all, and I think this speaks a lot to the social structures which we live in. I think that we can discuss quite often that everyone, and we like to think that everyone starts out equal, but I think it's becoming more and more apparent, especially when we look at HIV care, that that is not the case. I didn't personally attend the Women and Children one, so if I don't seem that I know a lot about this, I apologize. Women-centered care is needed to provide optimal support to HIV-positive women. We know that women make up half of the population, so I don't understand why we're not taking this time to actually look at women. Women clearly have needs which we need to address, and they clearly are in absolutely no way inferior to men. Now, if we can find some way to get them into the studies, if we can find some way to, sorry, that was a very risky comment. If we can find some way to get them into the studies, I really do believe that we can make some serious headway and really progress the future of women, especially in regards to HIV. Decreased rates of AIDS defining cancers we have seen, but there's an increase in non-AIDS cancers. Also, vaginal bacterial balance is vital to avoid infections and undesirable reproductive outcomes. So, time to suppress HIV in pregnancy varies. Preterm birth rates were increased. Also, low progesterone can negatively affect pregnancy. Protease inhibitors cause this in a mouse model. My friend Heiko at the back would like me to say, in rats. Women who support in pregnancy can still rebound prior to delivery, so we know that we can affect transmission to the baby. I also think we do need to, again, consider women and really pay attention to what women have to offer and make sure that they're also centered in the care, not just about the infant as well. So we do, sorry, I only have 2 minutes, so I'm going to rush. One thing that I found really interesting was comparing a couple to the new Complera. While we know that Complera is a single tablet regimen, I think it's going to really expand our horizons and really expand the access to treatment which people are going to be able to receive. A triplet is fantastic. However, it does cause a lot of problems, which we all know. So Complera is a nice benefit and a nice added option for a lot of doctors. Also, 50% have a greater chance of viral suppression under modified directly observed therapy, so MDOT, which I also found important. If we actually look at a patient and access them from all angles, we can actually help them suppress the viral load and therefore control the disease. Preliminary results from the first study of the efficacy of an HPV quadrivalent vaccine, also extremely important. The fact that we now are looking at HIV positive people and especially women for the sake of this study, and for HPV. So we know that in this study that we have seen amazing results for the 16 strain of the virus of HPV, which actually is the #1 cause for vaginal cancer, or cervical cancer, sorry. I don't have a vagina, so I'm not clear about it all. Not since I checked anyway. We also learned that when we control for specific proteins, we can increase the concentration of certain drugs that reach areas of the brain and also the testes, which I think is very, very important. So we can actually make the drugs a lot more effective. I'm glad you're laughing. Also using, like I was saying, using next generation sequencing, we're able to attack and acknowledge mutations before they happen and before they progress to a point that we're going to be unable to address them. So it's also a huge breakthrough, and we also can replicate it across labs. So for cost-affecting and cost-saving measures, it's a very important study that was done. So thank you for that. Yeah, that's pretty much all I'm going to say. So thank you very much.
Okay, so my name is Chiro Vicignano. I work for the Committee for Accessible AIDS Treatment. I'm a peer research associate. I work as a peer educator, and I'm a youth support worker for the AIDS Committee of Toronto. First of all, I want to thank everybody in the epidemiology team, and a big shout out to Lara. She's there. She's our team lead. Without her, we wouldn't been able to understand epidemiology and have the confidence to go to these sessions. So these are some of the common things that we found throughout the sessions that we sat upon. So what are the supports that are required to strengthen the prevention response? So we have to acknowledge syndemics. For example, anxiety, depression, use of party drugs among MSM, but we have to be aware of the stigmatizing language. We have to have testing services should also provide harm reduction information, resources, and support. And it's important to situate research findings in their broader social and health realities faced by marginalized communities. The community-based perspective and linkage to care. Here we saw in the ATRAC study, despite the high rates of testing, persisting high prevalence of HIV among Aboriginal people, it raises the question and it calls to action. Critical link to prevention, testing, and harm reduction strategies, like I mentioned before. And the importance to have research rooted in a community perspective via partnership with other local organizations. Then we have access to services and marginalized communities. Anonymous testing, we found out that it's more likely to be used by MSM and young adults. Spatial isolation in high risk in sex workers, it might become to the impact of the built environment they're in. The mother-to-child transmission in Aboriginal communities calls to think about the need to determine appropriate service for ARTs and supported pregnancy programs. And then some of the commonalities that we saw throughout every session is cost effectiveness. And we know that community-based programs and investments in HEART reduce overall healthcare costs in the long term. And cost to existing community-based prevention programs have immediate and long-term consequences. And these are some of the statistics of some of the numbers that we saw that caught our eyes. It's like $1 invested equals $50 saved. $1 million invested equals 21 HIV new cases averted over 9 years, and 8,800 cases averted and saving $3.3 billion. So this was a quote that we saw from the plenary that everybody in our team was taking upon. It's like, know your epidemic, know the response, know the action, and refine the action. And then we have a need to provide innovative yet pragmatic evidence-based approaches to prevention. The treatment of prevention is an important approach, but we must be critical of its applicability in different populations. And newer prevention strategies and technologies should complement and not undermine community prevention initiatives. And then we have social support for marginalized populations. The role of peer involvement. This came a lot during this CAHR conference, which is great. Is building trust, providing testing and counseling services. Intensive case management is one approach to linking target populations to care and retaining them in care. And the need for interventions that are sensitive to culture, gender, and other social realities. For example, the community health workers in population of internally displaced women. And then also, another commonality, we saw the cascade of prevention and care. And I just want a quick reminder of the cascade. It goes from infected, diagnosed, linked to HIV care, retaining care, need for ARVs, on ARVs, adherence, and undetectable viral load. And then we must ensure an effective and high-quality cascade of services at the entry point of testing. And we also saw throughout the sessions that treatment should be offered at diagnosis. In acute care study, 94% of the patients agreed to an HIV test. And there were missed opportunities for testing due to the healthcare providers' discomfort in offering HIV testing. Okay, that's about it. So thank you, everybody.
Hi, my name is Kira Hogue. I am with Ask Wellness out of Kamloops. And I perform a couple different functions at Ask Wellness as a social worker there. I am the traveling safer sex lady, delivering education and harm reduction to youth and rural communities, as well as individuals in addiction rehabilitation programming. My second hat there is as a health navigator, working with individuals with chronic healthcare issues, supporting them as a liaison with medical practitioners, support groups, and other services, including St. Paul's Hospital. So in Track D, these are some of the issues and things that stood out for us that were of an important nature. And in men who have sex with men, it was really profound to know that no matter where you are in Canada, Africa, Australia, men who have sex with men face multiple forms of stigma, as stigma is universal. And that gay men have unique strategies for prevention above and beyond public health official line. These unique strategies have strong points and weakness points, but are nonetheless knowledge exchange and application. So we're looking at community-created strategies. All resources, services, programming, counseling, and prevention messages must be tailored to specified targeted groups, cultures, and cognizant of the audience. And I think we've seen that over and over in terms of looking at demographics and groups. In terms of diversity, rates of HIV infection in Aboriginal communities have skyrocketed because the warning signs in the early 90s were ignored. Because they are not represented in media and prevention messages, Black women do not perceive themselves to be at risk while their HIV infection rates are increasing. And cultural differences must be recognized and respected, and interventions should be tailored to that community's specific needs. Interventions must draw from peers recruited from specific cultural groups. And as stated previously, having folks from those communities being involved in researching is so important. Multidimensional, community-based, and holistic approach, inclusive of families, offer the best hope. In terms of gender, overall, heterosexual men are invisible in the HIV community. And attending the Forum on Black Men in Toronto, who identifies heterosexual being completely misplaced in terms of HIV status, and having messaging that represented their group was very interesting to me. Women are underrepresented in medical research. Young Aboriginal women are overrepresented due to colonization, intergenerational trauma, and drug use. And pregnant women need holistic HIV-specific prenatal programming, including peer support, multidisciplinary medical services, and education. The community-based research process, which we thought was important to include, translation and cultural adaptation are key to developing successful national community-based projects. Effective collaboration between community and policy makers, including international collaborations, are needed. And to be truly empowering, peer work must move away from tokenization and marginalization. A quote that stood with us: "Empowerment is not simple." Research must value the diversity of knowledge sources. And in terms of harm reduction, we were all very engaged by the CEDAR project as it identified the linkages between addiction, transient living, and involvement in sex work in shaping HIV risk. The trans community faces much marginalization, discrimination, and violence when accessing medical services and addiction programs. And they're identifying that they don't feel like they fit in any of those services, denies them from the service, and thereby improving their quality of life. An examination of youth who use crystal, methamphetamine, and jib, the multiple health harms and social costs that result from heavy use, reflect the need for targeted youth programming. And one quote that stood out for me is a youth that said, "It's boring, boring, boring on the street." So to hear that and knowing that they're using crystal instead of things like crack cocaine, where all you're doing is chasing crack cocaine, with crystal you're able to enjoy your life, and there was a terminology of functionality, that youth felt they could actually enjoy things again. The problem with that is over 4 years where they were functioning, within 4 years they were starting to lose obvious health, social risk. There was costs in terms of their cognitive abilities and abilities to contribute to the community. This is us. On behalf of ASK and myself, I would like to thank CATIE and CAHR. CATIE does amazing work, and I know that the leaders of the CATIE group and all these beautiful people, we spent a lot of time together talking about important things, and I'm happy to have got to spend a bit more time with each and every one of them. Thank you so much for showing up this fine Sunday morning.
Good morning, and thanks again to all our previous speakers. It was a fantastic session. Well, we're going to start our last special session of CAHR, and thanks everybody for attending. I see a lot of people at the door, so why don't you move in and find some seats? I think there are a lot in the front and on the side here. And while you do that, I'm going to introduce the topic and our speaker. So this is our third special session, which we chose based on some of the media coverage that came out of the CROI conference earlier this year, and it's entitled Early Initiation of Triple Combination Antiretroviral Therapy in HIV-Infected Newborn Infants. Is Cure Possible? And the main speaker is going to be one of my colleagues and actually a friend, Dr. Ari Bittner, who is an associate professor of pediatrics at the University of Toronto, an infectious disease specialist at Toronto Hospital for Sick Children. And amongst all his other duties, he served as the chair of the Canadian Pediatric AIDS Research Group between 2008 and 2012, and serves with me on the CTN Scientific Review Committee, so I know he's a very, very busy person. Ari, please come up. Thank you.
Good morning, everyone. And now I see what they mean by the bright lights. Thanks to the organizers for letting us present this. This was a last-minute request on our part, and it came after the report that was presented at CROI. And I'm presenting on behalf of my colleagues at Sick Kids in Toronto, CHIO in Ottawa, St. Justine in Montreal, and individuals from the National HIV Laboratory. So I don't have anything to disclose other than one honorarium that's listed there, and it had to do with a medication that I'm not talking about today. So what I'm going to do is, in about 20 minutes, I'm going to talk in 3 sections. So there's 3 sections to this. First, I'm sure most of you, if not all of you, have heard about the case that was presented at CROI, but I'm going to go through that case in a little bit of detail just for those that may not know some of the details. And then I'm going to talk about the current guidelines and evidence for those guidelines for combination antiretroviral therapy as HIV PEP in neonates. And the reason I'm going to go through this is the current guidelines do not support the use of triple combination, so it's a little different than in adults. And the second reason I'm going to go through that is that we in these 3 centers actually do use triple therapy despite the guidelines. So I think we have something to contribute to this discussion. So the last part will be a quick review of some of the data that we've managed to put together in 3 weeks. So there's still more to do, but this is just some preliminary data. So I'm going to start with the case. So this was a 28-month-old infant that was born a little prematurely at 35 weeks. The mom's history is that she was diagnosed with HIV infection intrapartum, so she had an intrapartum rapid HIV test done. As a consequence, she didn't get any antiretroviral therapy before delivery, and also because the delivery was precipitous, she didn't get any intravenous zidovudine either. Her viral load was subsequently found to be relatively low, around 2,400 copies per ml, and her CD4 count was normal, and she had subtype B virus. The infant was born by vaginal delivery, had a rapid HIV DNA PCR sent, turned out to have a viral load of around 20,000 copies per ml at the time. When the DNA PCR result came back, this child was placed on triple combination therapy with zidovudine, lamivudine, and nevirapine at around 31 hours of life. One point to make here is, I mentioned this before, the current guidelines would not advocate for this triple combination in neonate, and that's because of lack of data on dosing and toxicity. So they used treatment doses of these 3 medications. This is just showing what happened with the viral load in this child. It dropped from around 20,000 copies per ml. You can see gradual decline down to less than 50 copies per ml by about 1 month of age. One point I'll make about, you can see the change of medication there from nevirapine to Kaletra, so lopinavir, ritonavir at 7 days. The reason for that, I don't know for sure because I didn't speak to them, but in general, lopinavir is not recommended in the early neonatal period because of some serious toxicities that have been reported. So the likely explanation is that. So this child, what was somewhat different about this child was that it was lost to follow-up at around 18 months of age, and consequently the antiretroviral therapy that the child was on was stopped by the mom. Fortunately, the child was re-engaged in care at around 23 months, at which time the child looked well and had an undetectable viral load. So just to, again, come back to some pediatric aspects here, it would be quite uncommon for this to happen. In general, if a young infant is taken off combination therapy, they will rebound very quickly and typically to very high viral loads. So this is somewhat of a unique finding, and because of that, they went on and did some more investigations. So to start with, their serology, both by ELISA and Western blot, was negative on 2 occasions. They looked for HIV-specific CD8 and CD4 responses. So this is another type. This is cell-mediated immunity responses, and couldn't find any specific to HIV. They didn't see any evidence of immune activation, and the CD4 counts were normal. So then they did some additional investigations. They looked for proviral DNA of the virus in peripheral blood mononuclear cells, resting CD4s, activated CD4s, and monocyte-derived cells. And they, in most of the assays, could find none. In 2 of the assays, they found very low levels of proviral DNA. And this sometimes just, this does not necessarily mean viable virus, so it's hard to interpret this necessarily. They did some highly sensitive viral load assays. One of them was completely negative, and the other suggested the presence of 1 copy per ml. They tried to detect replication-competent virus in a culture of 22 million resting CD4 cells and were unable to do so. They did exclude the Delta 32 CCR5 mutation, which was important as well. So the bottom line, and this is basically a wording taken from their conclusions, they indicated this was the first well-documented case of what they referred to as functional HIV cure in an HIV-infected child. They suggested that very early antiretroviral therapy in infants may prevent the establishment of latent reservoirs and achieve cure in children. They suggested that this had the potential to transform the current treatment practice in HIV-infected newborns if this were to be replicated. And lastly, they suggested that some trials looking at combination therapy in infants were in development. So that's the summary of the case. Now I'm going to switch gears to combination antiretroviral therapy as HIV PEP in neonates. and I'm going to talk a little bit about the background evidence and what the current guidelines are. Okay, so first, this is relatively old data, but still useful. This is in the zidovudine monotherapy period. These are data from New York State, and what they did is they looked at mother-infant pairs where the zidovudine was started. It looked at rates of transmission depending on when the zidovudine was started. So you can see that if it started antenatally in mom, had the lowest transmission, that is to be expected. But the main point that I wanted to make from this slide is if mom does not get any treatment at all and you start zidovudine in the infant within 72 hours of life, you do impact transmission. So zidovudine monotherapy in the infant can reduce transmission. You can see started before 72 hours or within 72 hours versus late, there is a difference. Okay? So this is kind of analogous to the zidovudine monotherapy in the healthcare workers study. Okay, an important study that came out in 2012 was a randomized study of neonates. So this is neonates where moms did not get any treatment. So these are diagnosed at the time of delivery and only the infant is treated. These are exclusively formula-fed infants, so there's no question of breast milk transmission. And they randomized into 3 groups: zidovudine monotherapy for 6 weeks, or zidovudine with other medications in 2 arms. One arm got 3 doses of nevirapine, 3 doses during the first week, and the second arm had a 2-week course of lamivudine and nelfinavir. Their overall results suggested a transmission rate of around 8.5%. And of those, about 6% were deemed to have been in utero transmission. How is this generally done? It's by convention. If you have a positive DNA PCR in the first 48 hours of life, it's surmised that that infection occurred in utero. One can argue that a little bit, but that's the general convention that we follow. And overall, they found that the risk of transmission was higher in the monotherapy group. I don't think that's a huge surprise. This graph is showing the rates of transmission, taking out the ones that had the DNA PCR positive at birth. So basically looking at ability to prevent infection intrapartum during the process of delivery. And you can see that this was a significant difference between zidovudine at around 5% versus the combinations somewhere between 2 and 2.5%. Okay. So based on that study, the current Department of Health and Human Services in the US, the guidelines that are online and used by many people around the world, they recommend in the setting of no treatment in mom, zidovudine for 6 weeks to the neonate and 3 doses of nevirapine during the first week, based on this study. The nelfinavir option is not there because nelfinavir for neonates is no longer available, so the only option is this dual combination with 3 doses of nevirapine. And they specifically say that the decision to combine other drugs should be made in consultation with a pediatric HIV specialist, preferably before delivery, and should be accompanied by counseling of the mother on potential risks and benefits. In general, again, to reiterate, there's been a lot of, we don't know the right dosing, and so there's a lot of concern around toxicity. My perspective and those of others is a little bit different despite those guidelines, and so this is where our data will come into play in a minute. But from my perspective, so even with the combination studied, the neonates had a risk of somewhere between 2 and 2.5%. If you compare that to the risk from an average needle stick injury in a healthcare worker of 0.3%, if we're giving triple therapy to the healthcare worker for that kind of risk, why would we not do so for someone who's got over 2% risk? Doesn't make sense to me, and because of that, that's one of the reasons. The second reason, which I think is important to keep in mind, is I worry quite a bit about 3 doses of nevirapine, because what if that child is infected? Then they've been exposed to, and you make that diagnosis a little bit later on, they end up with NNRTR resistance, they've just started their life and they've blown a whole class. So that's a second potential concern with this strategy. So that's the background, and now I'm going to talk about our approach and some preliminary data. So we've used triple combination therapy for neonates that we feel are high risk. So these are scenarios like the cases described before where moms did not get treatment, or we know their viral loads are high, or we have concerns around adherence and so forth. The regime we use at Sick Kids in Toronto and CHIO in Ottawa is a nevirapine-based regime where zidovudine and lamivudine are given for 4 weeks and for 6 weeks, and the nevirapine for 4 weeks. We stop it a little bit earlier again to avoid the possibility of resistance. At St. Justine in Montreal, they've tended to use protease inhibitor-based treatments, and more recently they're using some more nevirapine as well. I should say that for the Sick Kids and CHIO combination, we did have a lot of meetings and discussions with multiple people from different fields, and we did come up with a consensus document that has been circulated to the various clinic leaders, and that was where we decided on the nevirapine-lamivudine-zidovudine combination. Okay, so my goal here is to now talk to you about a review of high-risk HIV-exposed children who receive triple combination HIV PEP. And the key study questions, and these sort of came out of listening to the Croy report, is can neonatal combination therapy achieve sustained virologic suppression and quote-unquote, because I don't really like this term, functional HIV cure? And then the second question, which I think is important to address because of the authors of many of the guidelines, is does it seem to be tolerated well? Okay, so we have, over the years, 129 neonates that we considered high risk and therefore got treated with triple therapy. You can see that the nevirapine-based regime was used in 53. The others were a protease inhibitor-based regime. In terms of transmission, HIV infection was confirmed in 9% in 12 cases. And this is based on the standard definition in neonates. So for those that are not familiar with this, we can't use serology testing in young infants because they will have transplacental maternal antibody. Their antibody test will always be positive. So we have to use molecular detection techniques. And so the standard way of making a diagnosis in a young infant would be 2 assays that are positive by either PCR or viral load or so forth from 2 separate samples. Okay, that's a standard definition. It's in all the guidelines in terms of making a diagnosis in an infant. So of the 12, 6 had a DNA PCR done within the first 48 hours of life, and those were positive. And as I mentioned before, that suggests, not confirms, but suggests that their infection occurred in utero rather than during the process of delivery. And of the 12 cases that were infected, 5 achieved a sustained virologic suppression, and I'm going to focus a little bit more on those going forward. The 7, unfortunately, have failed at various points because of poor adherence and so forth, and so we know they're infected. They've had elevated viral loads and so forth. I'm going to start with one of the cases of those 5. So this was a 28-year-old mom who was diagnosed with HIV about 6 months before delivery. For reasons that I do not know, she was only initiated on treatment about 6 weeks before delivery, at which point her viral load was close to 100,000 copies and her CD4 count was 190. We did not have a viral load prior to delivery, and it was because of this that the neonate born prematurely was given triple therapy. So this was a nevirapine-based regime because this was a sick kid's case, and this was one of the ones that had a birth PCR that was positive. This is just showing the viral load decline. You can see a relatively low viral load, 1,890 copies per ml on day 1 of life. This is very low for a perinatally infected child. They usually have very high viral loads. And you can see the 2-phase decline to 276 and 86, and the first documented undetectable viral load at day 189. This child is now 6.5 years of age, has remained on the same combination, and has maintained a fully suppressed viral load since. This table summarizes the 5 cases. We've only got preliminary data because we haven't had a lot of time to do this. You can see their age ranges from 2 to 6.5. You can see their initial viral loads there. I will point out that it's only this one that has a viral load from day 1. The other four have viral loads from around 2 weeks or 1 month. The reason for this is typically we wouldn't do a viral load until we get the DNA PCR back. And so once the DNA PCR comes back positive, then we'd send a viral load. So a point to make about those viral loads is this is under 2 weeks, or in this case 1 month of therapy. But looking at these numbers, it's likely that none of these infants had very high viral loads. I would guess, if I were to guesstimate, it couldn't have been anything higher than 10,000. And then here you can see the time to, or the first documented undetectable viral load, their age in days, and you can see it ranged from about 65 to 189. The last two columns show sort of our very preliminary data that we've managed to get on these. We had to get this through ethics. We only had a month to work with, so we still have some work to do. But in essence, of the 4 tested so far, all have negative serology, both by ELISA and Western blot, and there were no bands on the Western blot. And all have negative, or 3 had negative PCRs by the commercial available assay in the provincial labs, and 3 had negative PCR also using a highly sensitive PCR assay with a limit of detection of 5 copies per ml. 1 child had an indeterminate result, and that's being repeated now. Okay, now in terms of toxicity, so in general, overall, the medications are reasonably well tolerated. You can see a third with non-specific symptoms. I'll come out and say right off the bat, in the vast majority of these, this was not felt to be related to the medications. Babies are often irritable because they're hungry. They often have a little bit of spit-ups, and they very often have loose stools, and it's nothing abnormal. Rashes are also a dime a dozen in babies, and most of these rashes were thought to be unrelated to medication. But in about 8% of cases, there was a possibility that these symptoms were related to medication. Of the 129 infants, in 5 the medications were discontinued early, so this is important. We need to keep these in mind. In 2 cases, it was because of anemia. In 1 case, a hemoglobin at 2 weeks was 60, and this child needed a transfusion. 2 children on an Ilfinavir-based regimen, 1 had an elevated CPK of around 1,000, and 1 had significant vomiting, and so the regime was stopped early. And importantly, we only had 1 child of the 129 who had a rash that we felt was related to nevirapine and had discontinuation early. I'm going to go through this quickly because I'm probably running out of time. I'll talk about the anemia a little bit more. So anemia in neonates is very common. It's most often physiologic. Their fetal hemoglobin goes down, and they do go through a period of low hemoglobin. So having a hemoglobin of 100 at 1 month is not unusual. In addition, these are things that are seen very often with zidovudine monotherapy. So the degree of anemia overall, I don't think is all that concerning. There weren't any with less than 70, except for that one that I mentioned before at 2 weeks. This is 1 month data, so you don't see the 60 there. And in all of these, it's reversible. Neutropenia of less than 500 is of concern. So that's something that needs to be watched as well when on these medications. But in all of these infants, these things resolved after stopping the medications. Okay, so to summarize and conclude, perhaps the most important one that is often lost when media reports come out is, from my perspective, it is unacceptable that we needed to give triple CART to 129 neonates. This means that we're not making a diagnosis in mom in time, and we're not giving mom treatment in time, or there's a problem with adherence, and that is not good. So that's the first conclusion. I'm going to go through this quickly. I don't need to show you all the results. This is Canadian perinatal HIV surveillance data, just looking at a little close to 3,000 infants. And the main point I wanted to make here is just to reinforce, if you look at timing of maternal treatment initiation, if there's none given versus if it started but less than 4 weeks before delivery versus more than 4 weeks before delivery. And the bottom line, you can see rates of transmission 8.3, 4.8, and 0.1. Not telling you anything you didn't know. If you give the treatment it's taken, you don't transmit. And these 2 cases, in both of them, there were problems with adherence. So bottom line, if you prescribe it, it's taken, you suppress your viral load, the child will not be infected. Okay, second conclusion, triple combination therapy in neonates is generally well tolerated. Anemia and neutropenia are important to look for. Discontinuation of therapy due to toxicity did happen in some cases, but not excessively so. There are some significant gaps that remain, and this is why the guidelines are as they are. We do have very few formulations that are useful for neonates, liquid formulations and so forth, and we also have very limited data on dosing for medications. So there's room for improvement there. And the last summary and conclusion point is that sustained virologic suppression with early initiation of neonatal combination therapy is associated with negative HIV serology later on, and negative HIV DNA PCR at a detection threshold of 5 copies per ml. So our very early findings do support the possibility that, well, that it's plausible that neonatal combination therapy could prevent establishment or reduce the size of reservoirs. So I think our case is a little bit different than the case at CROI, in that our kids are still on treatment, so we can't see if they're going to rebound or not at this point. So what do we do with the 5 children going forward? Well, we're in the process of doing some more sophisticated assessments to see if we can find any viable virus in them. I put some question marks there. It is difficult to do invasive procedures in children, and I'm not sure what we would do with the results. So if we did a gut biopsy and didn't find any virus, would that be enough for us to say, let's stop therapy? I'm not sure. So these are things we're going to have to decide. We do have to look for, make sure that they don't have any mutations that would have prevented them from acquiring the infection or reduce their risk. And then lastly is the question of whether to stop or not to stop the treatment. And I'm not brave enough to do that. I worry that if we stop the medication in these children, they will rebound and then they will reestablish the reservoir, and then I haven't done them any good. So there's a lot to learn from this case, and I guess we'll see what happens going forward. So I'm going to stop there. For people that are interested and want to look at the guidelines in relation to neonates, they're online, and these are the pages related to neonates. And then there are 2 posters by the authors of the CROI case that are of interest. I didn't have time to go through this one, but it also has some bearing on this as well. Thank you.
I think we have time for 1 or 2 questions, if anybody has any questions. We'll see if there's hands. There's some microphones running around.
Hi, thanks so much. I'm just curious if any work has been done on animals, looking at the neonates in animals? And to see if once you suppress the virus, if you've suppressed it for good.
Yeah, not that I'm aware of.
Anybody else with a question? I don't see. Oh, this one here, I think.
Do we know what the status of the mother is? Did she require the viral load go up? Just to repeat, do we know what the status of the mother was?
In the CROI case? All I know is what is in the podcast, and I think that question was asked, and my understanding is that she was not on treatment right now.
Because that was a relatively low viral load. I mean,
it was,
not
yes.
knowing where she was in her stage.
Yeah.
Okay, great.
Yeah, my understanding is she was not on treatment.
Thanks, Ari. That was a great summary. How would you interpret that the viral load, the first viral load measured in these infants is relatively low to our common previous knowledge that, as you said, these infants have sky-high viral loads. Do you think it's because they have been measured already on antiretrovirals? And
okay, so I think certainly in the 4 that where the viral load assay was done 2 weeks, and in one case almost 4 weeks after starting combination therapy, that might have played a role. But generally speaking, as you say, a lot of neonates will have a viral load of 500,000 copies per ml when we start treatment. So I think 2 to 4 weeks would not have suppressed that amount. So I would speculate their viral loads couldn't have been much more than in the neighborhood of 10,000 or so. And the one case had a viral load that was around 2,000, and that was day 1 before starting treatment. So I think, you know, to speculate, I would say that if infection occurred in them, it occurred very close to the time of, as opposed to a month earlier, because I would have anticipated higher viral loads if it was that much earlier.